So with that said, we're going to have some opening remarks, and I'd like to introduce our two speakers for the opening remarks. And we're going to start with Miss Heather Hauck. She's a director of the Maryland Department of Health and Mental Hygiene, Infectious Disease and Environmental Health Administration. And I'd like to ask Heather to please come up, say a few words.
Good morning, everyone. Oh, that was great. Good. I'm usually having to ask people to say it again, but I see the coffee is working. I see some familiar faces in the audience, but again, for those who haven't been here when I've spoken previously at this conference, I'm from the Maryland Department of Health and Mental Hygiene, Infectious Disease and Environmental Health Administration, and I'm here on behalf of our Secretary Sharfstein, Dr. Sharfstein, as well as the Deputy Secretary for Public Health Services, Fran Phillips, and unfortunately this year, Renata Henry, who is usually able to join you, our Deputy Secretary of Behavioral Health, is not able to join you. So she actually asked me to provide remarks on her behalf as well. So I have a couple of things to share with you about our behavioral health efforts at the state. I also want to take the opportunity to thank the Danya Institute for holding this conference, and I hadn't realized it was the 10th year anniversary. That's quite impressive. But this is such a great conference to bring folks together to talk about all of the overlapping syndemic issues that we're dealing with in the country and certainly in this region as well across the DC, Maryland, Virginia, and other surrounding states. It's really an opportunity for folks to come together to talk about what's going on in research, what's going on the ground, and what's going on in the various federal agencies as well as the health departments. And I'm always impressed when I look at the agenda at the range of the evidence-based interventions that you all will be talking about and the service delivery approaches that you all as the experts out in the field bring to this work and can also collaborate and coordinate on. I know personally that we also have two speakers from my administration who will be speaking with you over the course of today and tomorrow. One is Kip Kasner, who's the Deputy Chief in my Center for HIV Prevention, who's going to be talking with you, and the other is Carmi Washington Flood, who is the chief of our Office of Faith-Based and Community Partnerships, and she will be working with you on the component of caring for yourselves, because it's such an important opportunity for you all also to have some time and space to really reflect on what you all need to do to keep energized and rejuvenated, because the work that you all do is so challenging out in the field. So our vision at DHMH and at my administration, which works across all of the disease areas, infectious disease areas, is really a healthy Maryland free from infectious disease and environmental health hazards. And in order to achieve that vision in the state of Maryland, we have to work in partnership, because we as a state health department obviously can establish policy and we can fund programs and we can help develop programs, but really it takes the partnership with local health departments and community-based organizations and other private and public sector agencies to actually make that work happen and those policy visions a reality. So again, it's very important that we work together with entities like Danya, with SAMHSA, with our other state and local health departments in the surrounding area. And the reason why that partnership is so important is because HIV is still one of the dominating public health issues nationally and in the state of Maryland. In Maryland in particular, there are over 29,000 individuals living with HIV. That translates to around 1 out of every 165 Marylanders is living with HIV in the state of Maryland. So it's a significant disease burden in our state. The majority of those cases are actually found in the Baltimore City and then suburban DC, so Prince George's County, Montgomery County, which is where you're sitting right now, and the Baltimore City and surrounding area. So there really is a corridor that runs from DC up through Baltimore into Philadelphia, where there's a significant disease burden nationally and along the corridor. And I know you'll be hearing from my DC colleagues as well about the important work that they're doing in DC to address that. In addition to HIV, we know that there's also a link between substance abuse and hepatitis, as there is with substance abuse and HIV. So one of the other things that we've been looking at, and we know from some estimates from our data, is that we have a significant burden of hepatitis. Unfortunately, because there's not significant funding at the federal level for hepatitis efforts, we still are talking about a lot of estimated numbers, but we know that the disease burden is pretty significant. And we also know that in Maryland, there was a study done that indicated that of the injection drug users that were studied, 90% of them were infected with hepatitis C within the first 2 years of starting their injection drug use. So there's a lot of transmission that's happening with our injection drug using population. The good news when it comes to our injection drug using population is that the cases of HIV have been significantly reduced over the past few years. So initially, in the early days of our epidemic, and even till about 2001, about 45% of our cases were among injection drug users. Now, in 2009, that's actually been reduced to only 18% of our cases are among injection drug users. So there's been a rapid decline between 2001 and 2009 in the proportion of injection drug users who acquired their HIV through that particular risk category. We attribute that largely to a number of different things, but very importantly to the robust needle exchange program that happens in Baltimore City that allows people to exchange needles for clean needles. And we think that that's a huge public health success that has really helped lead to the decline in injection drug using cases. We also have to make sure that we're talking about other drivers of our HIV and hepatitis epidemics, not only injection drug use, but other risk behaviors. And we really have to acknowledge that we have an alarming increase in HIV among our young African-American gay men and other men who have sex with men. And so we have to take every opportunity to make sure that we're addressing what in our state is a multi-pronged epidemic. We have an epidemic among our injection drug users, we have an epidemic among our gay men and other men who have sex with men, and then still 38% of our HIV epidemic is among heterosexuals. So at any given time, we think of it as a multi-pronged epidemic that we need to be directing policy and programmatic and funding efforts in order to address all those populations. We really are aspiring in the state of Maryland to a Maryland with no new HIV, hepatitis, or sexually transmitted infections. And so we have to really work together in order to accomplish that. And I just wanted to share with you two examples of an effort of efforts that we have undergoing in Maryland that is really a demonstration and a good illustration of the partnership that it takes. So we have been working with our sister agency, behavioral health agency, the Alcohol and Drug Abuse Administration. We call it the ADAA, for almost a year now to launch a sexual health and drug and alcohol treatment integration program. And the Kip Kasner, who's presenting to you at lunchtime today, will talk to you about this in more detail. But what we've done is we've actually provided training to 10 local substance abuse treatment counselors from local health departments, academic institutions, and community-based organizations. And these counselors are actually in their settings delivering an evidence-based group-level intervention called sexual health and drug and alcohol treatment with their substance abuse clients. And the purpose of that curriculum is really to open up the opportunity to talk about sexual behavior in the context of the substance abuse treatment. Because as you all know from doing your work, you cannot unlink or decouple sexual behavior and substance abuse. But it's often the thing that's not talked about in substance abuse treatment. The focus of the treatment is really around the drug and alcohol abuse and doesn't touch on the sexual health issues that the individual may be experiencing. And so this is really an opportunity to train the counselors out in the field to be able to use language and use an evidence-based group level intervention to talk about sexual health and the relationship that sexual health and drug and alcohol using behaviors have with each other. We are also partnering with an entity to make the materials for that curricula a little more user-friendly so it can be used more widely. And later on next year, we'll be actually expanding that initiative to more entities. The second example I wanted to give you is actually from Deputy Secretary Renata Henry. And that is to share the news that, that we are embarking on an integration of our mental health administration and our alcohol and drug abuse administration. So her vision for the integration is a service delivery system that supports and facilitates treatment for the whole person. Because again, it's very challenging, and you all know this, it's very challenging to separate mental health and drug and alcohol addiction behaviors. And so to parse it out into different entities really is not necessarily doing justice to the whole person as they walk in the door. It really is, in essence, a translation of the no wrong door approach to an individual by aligning substance abuse and mental health services. So what Renata's groups are doing, her administrations are doing, are really looking in three areas. Regulations. There may be dual regulations that are guiding the mental health administration and the alcohol drug administration, or there might even be competing regulations that make it difficult out in the field to deliver services. So first and foremost, looking at the regulatory process to try to streamline that. Second is to look at the possibility of integrating the administrations themselves when it comes to the operations of the two administrations. There may be some efficiencies or there may be some synergies that can be gained by integrating the actual administrations themselves. And then looking at how that might roll out over the next few years in various stages. And then the third area that the integration process is looking at is really financing. What are potential financing alternatives? And Ryan already mentioned, with the advent of healthcare reform, how is it that the financing may look differently for behavioral health, and how is it that these two administrations or an integrated administration might be able to look at the financing of behavioral health services in a different way? And certainly looking at innovation in terms of improved patient care and integrated systems is also the goal. All of this information is actually on the DHMH website under the behavioral health component of the DHMH website. There's a letter from our secretary, there's a letter from Renata, as well as the outline of what the various areas are that the integration will be looking at. There is also a public comment area as well, and I know Renata asked me to also share with you all that this is a public process, and so comments, suggestions are very much welcomed as they embark on this integration at the state level of two very important behavioral health components in our state. So in conclusion, I think it's evident that DHMH really supports and applaud the work that you all do on a daily basis out in the field. Certainly on the ground, certainly in those of you who do research, and certainly those of you who do the administration or the operations of your various entities. It takes all of those things in order to put together a comprehensive integrated behavioral health and disease-specific or somatic care model in all of your jurisdictions. We also want to recognize and thank SAMHSA for the sponsorship of a conference like this. It is unique and rare that there's an opportunity to bring together this group of folks, and so the support that SAMHSA gives Danya to put this together is really wonderful. And I think the other thing that's exciting about conferences like this is that we are living in very, very challenging times, whether that comes in terms of the economy that we're faced or the work of public health in general. And so the opportunity to really sit and have good dialogue over the next few days about the syndemics that we're facing and the efforts that need to be brought to bear is really to be congratulated and applauded. In order for us to reduce the disease burden and provide support to people with all of these infectious diseases. So I know for those of you who have been here previously, you've heard me say this, but I think it bears repeating. I truly believe that each of us individually and all of us collectively, if we work together in partnership, can really drive down these syndemics, whether that's HIV, hepatitis, substance abuse, or other behavioral health issues. And so your work and your partnership is really critical to achieving our common mission of reducing the transmission of STDs, including HIV, and of helping individuals in your jurisdictions, and including my state of Maryland, with HIV, hepatitis, and other infectious diseases and substance abuse. So thank you for the important work that you do. Thank you for allowing me the opportunity to, again, do welcoming remarks, and I hope you have a great, successful conference over the next few days. Thank you.
Thank you very much, Heather. Our next speaker up is Dr. Jeffrey Hoffman. Jeff is the CEO of Danya International. He's also the chairman of the board of directors for the Danya Institute. So Jeff is a very close friend of the Institute. So I'd like to ask Jeff to come up and say a few remarks.
Good morning. this guy was strolling along the beach, and he came across a lamp. So he rubbed the lamp, and a genie came out. The genie says, "You can have 3 wishes." He said, "Really?" He said, "But the only thing is, anything you get, your ex-wife gets double. Your ex-wife gets double." He said, "Okay, I'll go for that." So what's your first wish?" He said, "Well, I'd like $1 million. Poof, got $1 million, and his wife got $2 million. So, well, his ex-wife, well, I'd like a mansion, big mansion on the beach. He said, poof, got a big mansion on the beach, and wife got 2 mansions. He says, well, scare me half to death. Think about that one for a second. So here we are, 10 years of keeping it real. This is, it's been quite a long run here. 10 years focusing on outreach workers, on the intersection between drug abuse, HIV, hepatitis. It's really a very rare and unique conference that has really stuck with this issue and has been the main supporter of outreach workers in this region, in DC, Maryland, the whole region, all the way up to where we have New Jersey and Delaware. So this has really been the heart of supporting outreach workers in this area. Well, we're facing some new challenges. You know, what's going to happen with healthcare reform? You know, we've really tried to build the profession of outreach. We've developed competencies and guidelines and really helped to build the skill set of outreach workers across all of these conditions. They're at the front line. You're at the front line, on the streets, in the clinics, needle exchange, really oftentimes the only hand that's out there to bring people into the system. So what's going to happen under health reform? What's going to happen with the integrated services that Heather Hauck just spoke to us about? What's going to happen to the role of the outreach worker? Hopefully, in the next couple of days, including this plenary session, we're going to get a little insight into this issue. Let's hear about what they're thinking about in DC. We're fortunate to have some of the top leaders from the DC government who are working in this area to hear their thoughts on how are we going to adapt to this changing environment. Healthcare reform is great in many ways. We're going to have more coverage for more people. But what does that mean for the addicted person on the street? And how are we going to reach that person? Okay, there's more coverage, that's great. But how are we going to get them into the system? Are we still going to have the same kinds of tools and personnel and positions that we've had over the last 10, 20 years? So it's a big time. It is a scary time. And it's a time of uncertainty. So hopefully we're going to learn some insights over the next couple of days. And please ask your questions. You know, stand up, give your opinions, ask your questions, be engaged. We're going to have some key leaders here. Speak to them. Take the opportunity. Don't just, say thank you. We are appreciative, but engage with them. Ask them the tough questions and try to, get some insights into where we're going from here, as well as gaining some of the skills that we're going to be offering, some of the great speakers and skill building that we're going to be doing over the next couple of days. So welcome. It's an exciting time. It's in a time of uncertainty, and it's a time to ask some real questions. So here we are. I'm going to welcome up the plenary speakers. Thank you, Heather. And if you want to come on up and join us at the podium here. And I will make some brief introductions, and then we'll get started. our first speaker, we're very fortunate today. I remember when Dr. Mohammad Akhter was appointed as the director of the DC Department of Health several months ago. And as soon as that happened, I recommended to Ryan and the Danya Institute staff to see if we could get him to be a keynote speaker for this conference. I've known Dr. Akhter for many years, starting when he was the Commissioner of Public Health in DC in the early 1990s, and have followed his career as Executive Director of the American Public Health Association from 1997 to 2002. And then he was at Howard University for some years as a dean and a professor, and we're very honored to have him back with the DC, running the DC Department of Health. He's a great speaker, he's a very thoughtful leader, and I've always enjoyed hearing his presentations. So very fortunate to have him today. And please think about some questions that you want to ask him now that you have the opportunity with him up on the podium. So Dr. Mohammad Akhter.
Good morning. I said good morning. Good morning. That's more like it. Thank you very much. The coffee is really great. And, I got woken up by having the great cup of coffee. Again, appreciate very much you all coming down here. Congratulations to Jeff and his colleagues for the 10th anniversary and holding this meeting, HAHSTA supporting it, and inviting us to be here. Story goes that a poor man, was concerned about his future. And he said the best way for him to determine what his future is, that he will go to a palm reader. So he saw a sign walking through the street of a palm reader, so he goes and presented himself and asked the lady, please tell me what my future holds. And the lady looked at his hand very carefully and said, sir, first 45 years of your life, you're going to be poor and miserable. Certainly the man was very depressed, but he saw a little silver lining. He said, maybe after 45 years, my luck will change. And he said, what about after 45 years? And she said, then you'll get used to it. We are gathered here not only to learn from each other, but also to plan for the future. We can't find the future from the palm readers or can't get used to the way things have been. But rather, we can learn and actively plan the kind of future that we want. And we have the capacity, because in democracy, that's one of the choices. The choice is about participation. And what Jeff said is very true. If we learn and we act on it, we can change the course the way things have been. And it's for sure are some uncertain times in which healthcare reforms are being implemented. So what I'm going to do is to run by you some broader picture for Washington, D.C., how we are doing the healthcare reforms. Then I'm going to ask my colleagues here to fill in about the HIV part of the healthcare reform agenda, and then also fill in the substance abuse part of the agenda. So you will have the complete picture, and then we could have some answers, some questions and answer sessions. Those that I could answer, we'll be delighted to answer that. Those we couldn't, we'll commonly try to find the answer to those questions. In every state, since the president's bill got passed, there's been an effort to do something with healthcare reforms. Half the state decided not to do anything at all, but to oppose it, take it to the courts, and it's going through the courts, going to the Supreme Court. The other half decided to run with it and go as fast as we can. So DC is running as fast as it can. And it's now number 2 in the nation in terms of implementation of healthcare reforms. 96% of our adult population has health insurance today. 96%. So we are moving as fast as we can, and so there are some ideas and some suggestions that we'd like to get from you all to see how we can make it better. In each of the state, either the state assembly or the state legislature passes a bill and the bill gets signed by the governor to implement healthcare reform. In some states, the governor signs an executive order, and that sets the process in motion. And in our state, in our city, soon to be state, they decided to have an executive order and creating the mayor's implementation committee. And the committee then have 3 subcommittees. One subcommittee looks at the eligibility. Who and how should we expand the Medicaid coverage and who should be eligible? The other part is the insurance subcommittee that looks at how to create a cheaper insurance product that people can buy, it's affordable to the people, and how to create the exchanges. We're pretty close to passing the bill that will set the stage for creating the exchanges in DC. And the last committee is about how to change healthcare delivery system. And that's what committee that I chair, that's where you all sort of fit in, the work that you all do every day and the work that you will be doing with the reform. And here are 5 things that were assigned to this committee. The first thing is integration of prevention into the delivery of systems, healthcare delivery system. What does that mean, actually? It means that today in Washington, D.C., if you go and see a doctor, the doctor will do the test on you for your cholesterol, and he can look at you for anemia. He can look at you for your sickle cell disease, but he or she is reluctant to do the test for HIV. What this means is that every physician is going to get a letter this week that's going to say the HIV test is part of the normal physical examination. No consent is needed, nothing more is needed, and the insurance companies are going to get a letter the same way, saying this is a payable service. You must pay for this service when an HIV test is done. What does it mean broadly speaking? It frees up the money that we're now spending on HIV testing, that we give the money, so we can use it for other purposes in terms of expanding the service. Similarly, it's going to look at other areas such as screening for mental health or screening for other chronic diseases. So we are going to go full speed ahead in terms of implementation of prevention into the healthcare delivery system. It is crazy, if you will, that a person may go to a doctor and may be seen by 3 or 4 or 5 times in a year, but yet have no HIV test on the record. It can't be. It can't be. With 3% prevalence rate, you know, it's not a good medical practice. So the scope of practice will change in the district. Similarly, the issues of patient safety, issues of quality improvement, innovative approaches to healthcare delivery, and manpower training are part of the job of this subcommittee that I'm working on. We start with the prevention. We're going to go down the line. We're doing some work on manpower that I'm going to be talking to you about in a moment. One of the things that healthcare reform offers us is the expansion of services. You just heard Jeff Hoffman telling you about that's going to expand the services, but what does it mean? Once you expand the Medicaid and you move patients from your state or local funded dollars over to Medicaid, it's a match. In DC, it's a 30-70 match. If I pay everything for the HIV drugs, if I pay everything for substance abuse treatment from the city's own money today, but if I move these patients over to Medicaid, what do they do? Then I have 30-70 match. Then my money gets multiplied. I have a lot more money to be able to use for other purposes. And that's why in the District of Columbia is one of the few places where there is treatment on demand. There's no waiting list for HIV/AIDS drugs, and there's no waiting list for substance abuse. Why? Because we have done this match. We've done this swap. We've just taken the money from the city that we funded before and converted it into Medicaid, and that way we got the 30-70 match, and we have more money to be able to use it. And every state, every jurisdiction can do that. Insurance exchanges are being established, so there'll be a cheaper insurance products that people can afford and can buy. And finally, we believe in Washington, D.C., that no matter how well we try to cover everybody, there are always going to be people who are uninsured, particularly the illegal immigrants. And if those folks who are among us, living with us, and they don't have a place to go, they may be spreading the disease to others. And so the idea about all of this is to really have some safety net institutions. So we have a hospital, and then we also believe that there are some areas where state must do something, or the city must do something itself, because nobody has the expertise, such as hepatitis, sexually transmitted disease, and tuberculosis. So we run a clinic that's open to everybody because nobody else has the expertise. They don't see TB every day, so they don't know how to treat that. They don't see hepatitis C every day, so they don't know how to treat them well. So we have that service to continue that part of the process. We can give everybody an insurance card. Will that change their equation? What happened in Massachusetts when they did that? Because people couldn't find a primary care doctor. You need to have some place to go to. And so in Washington, D.C., we use the tobacco money to help build the clinics in the manpower shortage areas, particularly Ward 6, 7, and 8. And build these clinics with the tobacco money and provided 2 years' worth of running expenses for them. So they could run those clinics for 2 years. And that's the commitment that we made. Included in this are also 3 clinics that are in the schools that during the day help the school children, the high schools, and in the evening they are open to the public. By building these clinics and using the tobacco money to expand the primary care, everybody in the DC will have some place where they could take the insurance card and could get the service in their neighborhood or in their vicinity. Giving them insurance card and not having the access is not something that we believe is a good way of serving the need of the people. And we're very fortunate to get the 3 medical schools to adopt one of the clinics. So each of the school-based clinic is run by one of our university medical centers. So the quality of care is good, and it's a good working relationship for all of us. By 2014, we think everybody's going to be covered, and so then these clinics will be on their own. They collect the fee just like everybody else and be able to be in service. We can have these clinics built, but if there are no doctors, no nurses, no practitioners, what do we do? How do we meet those demands? Because some of those people are in great demand. Primary care doctors are in great demand, nurses are in great demand, and especially you can't find the social workers to be able to provide the services to substance abuse, HIV, and especially those people who have all 3 things, mental health, HIV, and substance abuse problems. And so one of the agenda is to expansion of manpower. How do we expand the manpower? And here are the 4 areas that we are looking at it. One of them is increase the numbers by funding the existing programs. And of course, there's a capacity problem there. You can't create a nurse overnight. You cannot make a doctor overnight. It takes 4 or 5 years. And then they have to go through the training program before they become to be actually practitioners. The other area is our boards of medicine, board of pharmacy, board of nursing are all examining how to expand the scope of practice of current people. For example, the pharmacist will be able to provide the immunization to the patients who show up. Why couldn't it be done? They are very highly trained. We can put them through a separate training program and make that happen. Similarly, expanding the scope of practice of nurses and other health professionals. So they're all being examined to see if we can expand their scope of practice so they could legally do more things than they are currently authorized to do. The third area, of course, is the use of technology. How can we meet the need of specialists in those areas where we have primary care? If somebody comes in and they need to be their eye examined or they need to have a consultation with the dermatologist, they're not available everywhere. But can we use the technology to do it on a remote basis? And finally, the 4th thing is that look at creating the new occupations. There may be a new kind of profession that's needed. And you just heard from Mr. Hoffman just a moment ago, that is this be the new kind of profession? And my colleagues in substance abuse will be talking about this. So we have the agreement with the University of District of Columbia and our community college to train the new kind of professionals. The mayor this year allocated $5 million to get the programs rolling. And so people could get free scholarship, could come in, and could expand either their scope of practice or could be a new profession that people can get into. And of course, we are one of the few places in the nation that's using its own money to fund the primary care training programs. So we are supporting the primary care development. We can do everything that we want to do in terms of providing the care to people who are sick. But if we don't do preventive work up front at all levels, prevention in the homes, in the daycare centers, in the schools, in the workplace, and in the communities, we're not going to stop the tide of people keep becoming sick and sicker and sicker. And we can have all the health workers, everybody else going after and taking care of them. There are 30,000 city employees. They can't take care of 600,000 people. So at the end of the day, we got to look at the prevention piece. And so these are 6 areas where there is either legislation passed by the city council or is in the process of passing and allocating the resources and saying, how could we create healthy and safe homes? How could we go ahead and do the healthy schools by removing the soda machines from the schools and providing healthy lunches and reinstituting the exercise in the schools? So this is the work in the progress where the mayor and the city council have come together and said, this is what we really need to do. It might produce a result 5 years, 10 years down the road, but we got to start now to make sure that, that prevention is in place. And finally, this piece is that we are exploring new ways of doing things. And one of the requests that we have submitted to Center for Medicaid and Medicare Services is to look at all those patients who are costing us today more than $100,000 a year. And guess what? All of those patients have one thing in common. They all have a mental health diagnosis. There are 2,002 such patients in the District of Columbia that cost more than $100,000 a year. Each one of them has mental health as one of the diagnoses. They may have heart disease, they may have arthritis, they may have something else. So they are coming in and out of the emergency room. Everybody's treating their arthritis and their heart disease, but nobody's paying attention to their mental health issues. And so the idea here is, let's see if we can figure out that if we work on their mental health issue, the behavior issue, can we reduce their running to the emergency room? Would they take their medication on a regular basis so they don't come in the middle of the night? And this is to the CMS, and it's going to get approved pretty quickly because we had conversation with them. And when it gets approved for the next 5 years, they'll be paying 90% of the cost of this work. 90% of the cost comes from the Center for Medicaid. And any state can do this kind of work. You need to pick your population, what you want to work with, and see if you can go through this process and show at the end of the day that if you treat their mental health and behavior component first, and then you can take care of the other thing, that you could do it a lot better. And then, of course, there's a new grant proposal now that's due on November 15th. It's a very short deadline, but anyone can apply for this too. And it's again for doing the work that we need to do on people who have high healthcare needs. And this is designed towards ensuring that people have access to care and they get the primary care, and they are patient and their caregivers are engaged in their own care, and finally that you are coordinating the care among the medical professionals. I mean, these are the kind of experimentation that's going to go on for next 4 or 5 years, or maybe even more, to see how we can serve the need of the patient better, and who best to be able to provide the input and advice and in writing and in person on these issues than you all who are on the front line and who have the experience. And finally, the last thing here is that the Institute of Medicine issued a report. We were all waiting very intently and saying they're going to come out and saying this is what the healthcare benefit should include, package will include, that we will have this many primary care services and this much hospital admission and this much outreach. When they came out, they said, no, we're not going to issue that report. But they, in fact, said, let's make the affordability as the base, that healthcare must be affordable, and then develop a package by listening to the people. And so HHS will be conducting now the listening sessions. And that is so very important. You don't follow anything that I said, but this one, that when these listening sessions take place, and you go down there and you talk to them and tell them about the need for inclusion of preventive services for substance abuse, HIV, and mental health, and the need for outreach workers, we can make a huge difference. If we didn't, we'd be excluded. If we did, we'd be included in the package. Because in terms of the cost, it's a much smaller cost with a much bigger benefit on the other end. But guess what? People who have the lobbyists, people who own the drug companies, they're going to be up there and saying, no, 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 let's go only for the treatment part of it. But the reality of it is, if we want to serve our people, our community, we need to be out in the community where the people are, try to be able to connect with them in terms of prevention, and then bring them into the care. So I stop here. Thank you very much. God bless you all.
Thank you, Dr. Akhter. He said he'll be able to stay for a few minutes, and we'll have the other presentations and then time for a couple of questions. Our next speaker is Alina McClerklin. She's a social worker and is currently the performance manager at the DC Department of Health's Addiction Prevention and Recovery Administration. She's a service practitioner, a social worker, clinical director, trainer, administrator, and has been dedicated to empowering underserved communities. You have her bio, Alina.
Good morning. I'm going to start off with an apology. I took my Girl Scout troop camping this weekend, and so sleeping on a ground in a tent has not done well for my voice. So please excuse me if at any point I sound like a 13-year-old boy. I will try to project my voice. Thank you. I just want to piggyback on what Dr. Hoffman had mentioned earlier when he had discussed these are exciting times, but there's also times of change. And change is not necessarily easy for everybody. So I want to just remind people of a quote from Charles Darwin. It's not the strongest of the species that survive, nor the most intelligent, but the most responsive to change. And I'd like to share APRA's story with you. APRA is the single state authority, and its task is to plan, fund, implement, evaluate, and regulate public substance abuse services. And APRA is going through this beautiful metamorphosis. As a social worker, I believe wholeheartedly in addressing the whole person. And now we have a chance with the Affordable Care Act to really start to follow that method. Before, we were operating in little silos, and our providers, even within ourselves, our prevention department, our recovery department, and our addiction treatment department. And so now we're moving towards having a real organized system of care that is responsive to not just the client, but also the client within the community. APRA has 5 major goals: improving quality treatment and recovery service, workforce development, expansion of Medicaid, prevention initiatives, and collaborations in creating formal linkages. Excuse me. For quality treatment and recovery services, we've done a number of things over the past 3 or 4 years. We started off by having uniform assessments. We now use the treatment assessment and protocol, which is the ASAM criteria along with the Addiction Severity Index. And this has allowed us to have a dialogue, a common, a common language to use with our providers. And so using the ASAM criteria has allowed us to make sure that people are assessed properly and go to the proper level of care. We also have made an emphasis on warm handoffs. So when they go to the level of care, they are then transferred to the next level of care. And this has been a significant improvement in our system. Prior to having our warm handoff policy, we had clients who went to detox, and then were just let out of detox. So now they're connected to residential, and then from residential, they go to intensive inpatient or outpatient care. This has resulted in a considerable savings in our system. Now, we also have made movements to increase access to treatment. We now have 5 sites of which people can access treatment. We also have decentralized our providers' intake sites for our ASTEP providers so that the adolescents can go into any neighborhood facility that they feel comfortable with and start their treatment process there. We've enhanced collaborations with other government agencies, and that has allowed us to really look at the client as a whole. We've also, I think, which is really important, have started comprehensive treatment plans. Prior to 3 years ago, our focus was substance abuse, and we just focused on addressing the client's substance abuse needs. Now our treatment plans reflect all the domains in the ASI, and so we're looking at the client as a whole. You know, we're looking at their employment, their education, their family. In addition to their substance abuse, we're checking their mental health, their primary care needs. We've also received a recovery support grant. And for recovery support, we've been able to, once a client has gone through treatment, we've been able to give them additional services to help them maintain their recovery in the long term. And this has had us, given us the ability to have relapse prevention, really address relapse prevention, and give people the wraparound services that they need to maintain their sobriety. And of course, we continue to evaluate and monitor our programs. So there's a couple of changes that we're doing, or we're working on. We want to make sure that all clients, when they come through the door, are given these 5 things. HIV testing. If they're a woman, we want to make sure that they're tested early on to see if they're pregnant, so that we can make sure that from the very beginning when they walk through the doors, we can get them the prenatal care that they need. Mental health screening and primary care screening. A question just as simple as, when was the last time that you went to the doctors? For our clients, the answer is usually maybe 5 to 10 years. So it's really important for us to link them to the services that they need to address their health needs. And then again, really working on the comprehensive treatment plans once they get to their providers. For our workforce development, we have decided to attack this from multi-levels. And so while we were focusing on providing training and increasing the capacity and knowledge for our workers, we also wanted to have an environment where they can successfully start utilizing their skills. So what we've done, and I think Dr. Akhter had already mentioned this, is for our ASTEP program, we had a 30% local match, and Medicaid has picked up this other 70%. This has allowed us to expand our adolescent program from 2 adolescent providers to 6 adolescent providers. And we've gone from servicing maybe 215 adolescents to now currently over 657 adolescents over the course of 2 years. We have multiple points of entry to make sure that it's easy for the providers to, for the clients to access our services. Consistent screening and assessment tools. We use the GAIN global assessments, individual needs, so that we can make sure that we have a uniform way of collecting information on our adolescents. We also did something different with our providers. We are paying for home visits because we knew that adolescents weren't necessarily always going to come to the provider. So now we can actually go to where the client is at. We've collaborated with the Department of Mental Health, the Department of Healthcare Finance, George Washington University, SAMHSA, and GW to make sure that we had a lot of support and assistance in creating a network that would work. We've got a lot of voices around the table to help us so that we weren't making programs in isolation. We really worked hard to remove the barriers that the providers and the staff had. We provided them with training, we provided them with ongoing support, we trained them in evidence-based programs so that they would feel confident when we expanded services. Now we're getting ready to do the same thing for the adult. And we have what we call the adult SPA, the adult state plan. And right now we're working on increasing the knowledge base of our certified addictions counselors. Right now, currently, we have about 517 certified addictions counselors who are going through a process of becoming licensed. And that licensure will allow them, the providers, to be able to bill for Medicaid, but it will also be a great opportunity for us to start improving our treatment services. When the workers feel comfortable about the new addiction sciences and they are trained in evidence-based models, they have a common background in addictions, then that just helps the network, which then helps the clients. We have Chapter 23 standards, which outline our need for having more qualified people sign off on treatment plans and sign off on notes. We have registered nurses who have addiction experience, LPCs, LICSWs, psychologists, and psychiatrists in these positions. Now this is where we're having a lot of problems because we need to attract those people to the field. As my role as the performance manager, it's one of the things that I feel strongly about. I also teach a class at Catholic University of master level social work students so that we can start addressing the need for having people be duly competent in co-occurring disorders. For substance abuse prevention, we have 4 prevention centers that cover all 8 wards in the District of Columbia. We have our peer strategy initiative goals, and they are to increase the attitudes opposed to alcohol, tobacco, and other drugs, delay the onset of first use and progression of risk, and increase in youth who are a part of their community's planning, decision-making, and evaluation for substance abuse prevention. And we feel very strongly that it's important to get out into the community, get these messages out so that the community can also help us with our initiative of improving treatment and stopping the cycle of substance abuse. Our collaborations thus far have been with the Department of Mental Health to improve our substance abuse treatment for clients with dually diagnosis. We work with HAHSTA, which my colleague will talk a little bit more about later, to reduce risky behaviors, increase medication compliance. Primary health care clinics, we've talked to them to help make sure that we do that warm handoff if somebody says that they haven't had a physical in 5 years. We want to make sure that they're able to be seen immediately and have a comprehensive physical. We've been working with the Department of Youth Rehabilitation Services, Child and Family Services, and Court Social Services to prevent the onset of and long-term substance abuse and minimize the risk for our adolescents. We've been working with the prevention centers to promote drug-free environments and empower our communities. And the Department of Employment Services, because once our clients are clean and sober, we want them to be able to find meaningful employment and so that they can sustain their recovery. And we've also been working with court services and offender supervision, CSOSA, to ensure that our reentry populations are connected to the services that they need. Our goal at APRA is to really be client-centered and have all of these points of entry working together to start where the client is at and to make sure that we're building a system that is connected, that is able to address the multiple needs of our clients so that we can promote health and wellness in all areas of their lives. We have a few grants that are helping us in this process. And our Minority AIDS Initiative targeted capacity expansion is a grant that we just recently got, and it's right on time because it is going to help us really implement this vision that we have and move this forward in a very quick way. We also have a recovery support project, which this is our second year, and so far this year alone, we've served over 1,800 people. And this has given people an opportunity to be supported in the recovery services. And this is a goal for APRA to make sure that we're not just looking at somebody and saying, okay, we're going to treat them and street them, but make sure that once we have them, that we're able to make sure that they have a soft landing and they're able to become citizens within a community that is healthy. So thank you.
Thank you very much, Alina. Our next speaker is Michael Kharfen, who's a DC Department of Health, HIV, AIDS, Hepatitis, STD, and TB Administration, serves as the Bureau Chief for Partnerships, Community Outreach, and Capacity Building. Michael.
Well, good morning again. I know you've been greeted a lot this morning, and so I'd like to join that. I work for the HIV, AIDS, Hepatitis, STD, and TB Administration in the DC Department of Health under the leadership of Dr. Akhter. And we are just recently, about 3 years now, we've actually integrated those diseases together within a single administration, which is sort of reflecting a national trend that you can't talk about any one of these diseases without the connections that exist and the comorbidities that affect the transmission and treatment of those diseases. That's been an exciting development on our part. And it's really, I think, very much that we are now in what I want to sort of describe as the third era of HIV. The first era, which I started on in 1985, yes, some years ago, and I have my half-century implements to help me through this presentation, that the era prior to the introduction of antiretroviral treatment, where basically, and many of us who've been working in this field a long time saw many of our friends and colleagues lose their lives to this epidemic. In 1996, the introduction of antiretroviral treatment really changed the face of HIV in the United States and around the country, and actually turned HIV somewhat from what was all perceived as a death sentence into something that one could survive and actually thrive. And now I think we are in the third era of HIV. And it's a very exciting time, it's a very challenging time to take advantage of these opportunities. What we've seen in this just past, actually 12 months, I think has been the most revealing 12 months about HIV in its field. We've seen new science come out that tell us that the effects of what treatment can do in terms of person's longevity, but also in the impacts it relates to prevention and the further transmission of the virus. We've seen the National HIV/AIDS Strategy. We just observed this year the 30th anniversary of the first diagnosed case in the United States, and we had the first strategy in 30 years to face this epidemic. We've now introduced a new word in our vocabulary, a word which, if many of you type it out, Bill Gates has not yet recognized, which is called syndemic. I say that because the little dotted lines all come underneath it every time you type it on the page. But we are now really looking up, and I would say that government is now beginning to catch up with you all, with what you've been doing in the field, and understanding that you can't treat any one of these diseases by itself. You really have to look at the entire effect about treating the person. And then the big game changer, which is the Affordable Care Act. and what healthcare reform means for the HIV system, for our community providers, and what it means to the individual. So that's a means of an introduction. I want to talk a little bit about what HIV looks like in DC. As you can see, this is based on our most current data. We are in our 64 square miles of the District of Columbia, soon to be a state, courtesy Dr. Akhter and our mayor, Vincent Gray, that we have an epidemic that is throughout our city. We have 8 wards, 8 jurisdictions, and as you can see, 7 out of those 8 are highly impacted. We have, based on our diagnosed reported cases, a 3% prevalence. The World Health Organization considers any percentage above 1% of a disease to be a severe and generalized epidemic, and ours is that. We also know that we have what we believe are higher rates of undiagnosed cases. The CDC estimates 21% nationally. We estimate between 1/3 and 1/2 of persons living with HIV in DC have not been diagnosed. And we are also fortunate to be one of the 12 cities, which has been the focus since the introduction of the National HIV Strategy, of which approximately just under about half of all of the cases of HIV in the United States are located. Just a little bit of cross-section across why we consider ourselves to have a generalized epidemic. Because when you look at any population of our city, any race or ethnic groups, across genders, you can see that we are well above 1%, and in some cases significantly above even our overall prevalence rate. Most outstanding, of course, is among African American men, where over 7% of African American men who have been diagnosed and living with HIV in the district. And when you look at African American men who have sex with men, we estimate about 25% of that population. But again, when you're dealing with a generalized epidemic, any percent over 1 is a focus population. And here in our district, next door, here in Silver Spring, but next door in DC, we are talking about every population group that needs to be addressed. So a little bit of a crosswalk between HIV, mental health, and substance use. Okay, this is where I do need the glasses a little bit. So as I think every of you know, because you experience it on a day-to-day basis, that many of the persons living with HIV have other co-occurring conditions, and mental health, mental illness, and substance use are major factors. So looking at our population, and our data is improving. Nearly half of our HIV positive persons in the district report some depressive symptoms. Almost a quarter of them, or 1/5 of them, have been based on our screening methodologies, and that have not been complete, or 1/5 are in need of mental health services. And to date, about 1,300 have been receiving mental health services through our network of provision of services. And this is an area that, again, is going to be subject to some change, which is that HAHSTA itself, through the Ryan White Care Act, have been funding mental health services. With substance use, again, a major factor among our population. Between more than a half, based on behavioral studies, have shown that have reported substance use, and then based on those who are HIV positive in terms of screening, or 1/3 or more are in need of some substance use services. And again, we fund a segment of the provider network to provide those services. I do want to mention in terms of hepatitis, because I know that's on your agenda as well. We have about, again, our surveillance data is maturing with respect to hepatitis. The federal government gives us all of $88,000 a year to provide hepatitis prevention in the District of Columbia. So the extent of our program is focused on some target populations, primarily injection drug users. About 12,000 persons have been diagnosed with chronic hep C in the district. Based on our behavioral studies of those with injection drug users, 90% report that they have been diagnosed with hep C. So we have a significant comorbidity between Hep C and HIV. So the new landscape of HIV, first and foremost, is the national strategy. If you're familiar with that, I sometimes recommend to folks. I was at a grant writing workshop the other day, and I said, carry it with you wherever you go, because many of what the efforts are coming from government is all aligned with the strategy, and certainly in the district we have embraced it. Whether that's its first goal around reducing new infections, second about access to healthcare, third on reducing health disparities, and the fourth, better coordinated services. And from what I mentioned before, again, but based on the science, and specifically around viral load, and I'll talk a bit about that in a moment, prevention and treatment are becoming more and more inextricably linked, that you can't really talk about them as separate silos any longer. And that has a distinctive impact. It's going to have a distinctive impact around the approaches that have been on around behavioral interventions with respect to HIV. For instance, in its latest funding opportunity to the jurisdictions, CDC is now focusing 75% of its core prevention funds on those who are HIV positive. So there's a shift going on between the efforts around those who are what we would consider high-risk negatives to those who are HIV positive. And that's going to have a relation, as well as that we're trying to seek, based on the strategy itself, stronger outcomes with respect to reduce infections, that there's going to be a focus on what many are calling sort of biomedical approaches on HIV prevention. As I mentioned, we are one of those 12 cities, and it gives us this opportunity. We've been doing that in the district already in terms of innovative approaches, particularly around HIV testing. We are one of the nation's leaders in introducing HIV testing, both in routine clinical settings, but then in outreach areas as well. We are been a beneficiary of the Enhanced Comprehensive HIV Prevention Plan initiative. We are also one of the 6 jurisdictions of the Program Collaboration and Service Integration, or PICSI, which is somewhat unfortunate name, but it really does give a tremendous platform around how we build more integrated service approaches. And then, as my colleague Alina mentioned, the new SAMHSA funding that went to the 12 cities that we're very excited about, because we really see this as the linchpin of our ability to better integrate and coordinate addiction, mental health with those who are living with HIV. And as I mentioned, the Affordable Care Act. So HIV in healthcare reform. The opportunities, I'll say challenges. First of all, or I'll update my slide. As Dr. Akhter reported, it's 96% coverage in the district, which in terms really changes what the shift we have been doing in terms of moving individuals who've been under the Ryan White care system. We moved over 1,000 of our clients into Medicaid. That's also moving 1,000 of them off of the AIDS Drug Assistance Program. So we no longer have the kinds of pressures around that many cities or many jurisdictions are facing with respect to waiting lists on ADAP, as well as access to care in general. We're following a medical home approach, really trying to link people to primary care practice, but also HIV care as a component of that. Eligibility, it's obviously we've taken a full advantage of the Healthcare Reform Act's extension of Medicaid eligibility, which allows us to transfer many of those individuals. And this is where, again, it gives us the opportunity to look at more ways to integrate our services, as well as about improving our quality of care. We have some other distinctive features of with the HIV healthcare system, in that we are a region as well, and we work collaboratively with the counties that are just adjacent to the district. We are one of what's known as the eligible metropolitan areas, as designated by HAHSTA. We actually have 4 jurisdictions, which I believe is more than any other, including counties in Maryland, Northern Virginia, and 2 counties in West Virginia, along with the district. So that presents some interesting opportunities and challenges with respect to the different healthcare systems that are available to persons living with HIV, as well as different quality of care standards across those jurisdictions. And workforce development. I think, and this is an area where we're catching up in the HIV field, not as well as our friends in addiction services, because we, as our part of the public health field, don't provide direct services. But one of the areas, and I think it's going to be where I think everyone is concerned about in terms of the field of outreach and counseling services as it fits into, particularly in the prevention side. But one of the key factors that we're going to have to address is that retention into care and reaching those individuals to get them into care. We are working on a peer-based community health worker model in the district. We think it's a very exciting opportunity, came under the Social Innovations Fund, and we believe that this is a great area of expansion with respect to HIV care. Cost efficiencies, of course, is going to be applied as well, and how that provides to our provider system. We have basically, I would call it a 20-year-old system in the district with respect to Ryan White, being the driver of the HIV healthcare system. And now that we're getting closer to with healthcare reform, it's going to have a question as to how they adjust and change in this new era, and how do they introduce cost efficiencies which they've never had to apply before. And well as how they build new collaborative models. For instance, how can we leverage the reimbursements that can come through Medicaid, for instance, where you have clinical and non-clinical providers working together, where the non-clinical providers are providing some of the outreach and retention and care services that the clinical providers don't have the capacity to do. And still reaching those that we know have HIV but are not in our care system, which we estimate around 40% in the district. So I'll speed up. We call this the 4 R's to our approach to care. By finding people who are diagnosed by who are HIV positive through routine HIV testing, and we know we're missing opportunities. Our behavioral studies show that 75% of persons who were diagnosed as positive through those studies had been to a doctor at least once in the past 12 months and had not been diagnosed. A survey we did of primary care physicians showed that 70% of them believed, yes, routine HIV testing is a good thing to do, yet only 20% of them were doing it. And then how do we get people who are diagnosed into our caring system? And navigation is one of our key features. Also, getting people back into care once they leave care. And we found a significant number of persons through what we call blitzes, where we actually start calling 7, 8 times possibly, or knocking on people's doors to make sure that they, when we've lost them out of care, because they haven't been to medical visits, or we don't have viral load or other CD4 count lab reports from them, that we make sure that they're in some form of care and treatment. Together, staying into care is a key piece, because as we've learned, viral load suppression means that you reduce the chances of transmitting the virus. And yet we have about 25% of those have undetectable viral load in the district. That's not good enough with respect to what we know about what medical care can provide. And so how we to address other cofactors, mental health, substance use, as being important parts of making sure that people stay into care. And then again, achieving that outcome of viral load suppression. So here's basically sort of what our map is of what we're trying to achieve. By finding those who are the true positives is through our HIV testing pieces. Diagnosing them and then getting them into care is part of where we determine their eligibility for antiretrovirals, getting them on antiretrovirals, and then achieving viral load suppression. Eventually, what we want these is to be right across the line. So that we can achieve close to 100% viral load suppression. About 50% of those that we do diagnose in the district are already eligible. That is, their CD4 count is 350 or under in terms of their need for antiretrovirals. And we've done a great effort with our provider community of partners in terms of getting people into care. We now have about 3/4 of our individuals that are in care within 3 months of their diagnosis. That is the overall goal, some of them within days. We have a program of expedited entry into HIV care. We call it red carpet entry. It means persons get an appointment within 24 to 48 hours. So those of you doing outreach, it's the effort to get people right into a medical evaluation. It is, again, many ways we are shifting our part of moving away from what had been oh, 3 minutes, good reminder, okay, is on referrals to actually making sure that people get into the care services that they provided. That we are, through this new funding opportunity, we hope to develop much stronger protocols in order to get people into care. And we, under the mayor's direction to us, we're also looking at fast track opportunities for those who are in severe conditions of mental health or substance use and living with HIV. So again, our core service integration pieces, opt-out screening, making sure that we are doing multiple morbidities, that we are looking at Hep screening with respect to, and we have new technology on the way, diagnostics with respect to Hep C and new antiretroviral treatments. That STD screening that we're doing, we are one of only 3 cities that has a school-based STD screening program, which is free and voluntary. We do about 5,000 plus adolescents a year. And we have a diagnosed rate of about 9% of chlamydia and gonorrhea. So this intervention affords us the opportunity, fortunately, that they have low HIV, that this might be a prevention strategy for HIV infection. Again, we were banned for 10 years from using our own local dollars for a needle exchange. We now have 3 different providers, and we're looking at ways to integrate more needle exchange services. And we are one of a handful of cities that has a public sector condom distribution program. So I think I've already talked about that. We need to look at, as you have done, look at the whole person, but have government itself follow your leadership in ways to make sure that we make it easier. And last I'll say is that, again, this catching up with the work that you've all been doing in the field is really a new culture for us, have to be in the public health field. And that we really do need to look at ways to better break down our own barriers and silos and to make sure that we can actually approach it on a client basis. So thank you very much.
Thank you, Michael. We've just heard 3 excellent overviews of what's happening in addictions and HIV and overall public health with relation to healthcare reform. We'll take 2 questions from the audience. We have 2 mics here, and while somebody would like to ask a question, let me pose a question for Dr. Akhter. I'm an outreach worker. I'd like you to read my palm. What do you see in my future? What would you advise me? Should I try to get one of those scholarships at UDC and get some training in the behavioral health or nursing, or what would you recommend, and what do you see for my future?
The future is what we make out of it. And here is what I would suggest that we do. First, work together to create a licensing system so that your services become billable and fundable under the healthcare reform. That's a very, very important piece. If the service isn't billable and fundable under healthcare reforms, government grants come and go. The local funds come and go. Your future is not going to be stable, and neither are going to be services to the patients. So that'd be first part. Start to think about what kind of training program we need to have so that you could get the license and the services become, again, billable. The second piece, which I am very interested in personally, is where do you get the most bang for your buck? Where are your services when you are out in the community? What do you do that would give the maximum benefit to the patient, to the community, and to the public health system? In my view, that includes 2 words. One is community outreach, other is home visit. Okay? If you can combine those 2, be the community outreach, home visiting, that is the future. Not only for substance abuse, HIV, but substance abuse, but all chronic conditions. It's also necessary for prevention purposes. So we are putting a lot of emphasis in the District of Columbia in the home visiting piece. of the thing. So we could find out what else that person needs to be able to be successful, and that's where the coordination comes in, where we can coordinate with other departments to be able to provide the social services.
Very interesting answer, and I think it sounds like a call to action. This is something we need to focus on, is how do we look at what's billable in the new healthcare reform, and how do we tie that? And one example is maybe combining home visits with outreach. So very interesting, and a very interesting call to action for what we need to do, what we need to focus on. Thank you. Thank you very much, and I want to give a big hand to our plenary presenters this morning. Thank you so much.